All right. Well, thank you so much, everyone, for spending your Friday afternoon with those of us here at the Council on Criminal Justice and Behavioral Health. My name is Brenda Graylish, and I am the Executive Officer of CCJBH. And you're joining us today for our Diversion and Reentry Workgroup meeting, today, July 15th, 2022. And I'm joined here with our Diversion and Reentry Workgroup Council member advisors. If they could say a quick hello, Judge Manley, if you want to click on the mic there and just say a quick hello.
Good afternoon. I'm Judge Stephen Manley from Santa Clara County.
Thank you. And Chief Jenkins.
Hello, I'm Mac Jenkins, a retired probation chief from San Diego County.
And we would typically have also Dr. Tony Hobson here, but he unfortunately was unable to join us for today, so we will look forward to seeing him next time. For the next slide, let's go through some housekeeping, and then I will go over the agenda.
Good afternoon, everybody. Just a few housekeeping for this work group. To begin, the work group will be recorded, so you'll have access to revisit the recording whenever you please. If you would like to make a comment, we ask that you use the raise hand comment button, and we'll place you in the order that you raised your hand. For any in-person participants, we currently don't have any, but if we do get people that show up, we'll ask that you complete a note card with your name and organization and your comment, and then we'll ask you to come to the podium and you'll be able to make your comment. We remind everybody to try to keep their comments to at least 3 minutes or less. We have a very rich conversation for today. If you don't get an opportunity to make a comment, we encourage you to send your comments to our email address at ccjbh@cdcr.ca.gov. Next slide. Also, just to review our website, our webinar policies, participation. In terms of participation, we welcome your participation throughout this meeting. Please note that disruptive behavior is not aligned with the purpose of this session and will not be tolerated. Any individuals disrupting the meeting may be removed without warning. And in the event of a security incident, this session will be ending immediately with no and not resuming. And we'll also send out a separate email to everybody that's participating today for further instruction. In addition, participant comments in the Q&A do not reflect the views or policies of the presenters, the Council on Criminal Justice and Behavioral Health, the California Department of Corrections and Rehabilitation, or its affiliates or contractors. By using the Q&A, you agree to keep comments relevant to the topic of today's event. While a variety of diverse perspectives and opinions are welcome, disruptive comments are not aligned with the purpose of this meeting, and you will be removed from the meeting. So without further ado, I'm going to turn it back to Brenda.
Thank you so much, Monica. So going forward, next slide, please, for our agenda today. We do have a packed agenda, lots to cover. We'll do a quick update on our Council on State Governments Justice Center diversion contract with a little quick Q&A with council member advisors and the public after that. And then we'll hear from our guests from the Department of State Hospitals today on their diversion program and new items in the budget from the IST Workgroup Solutions Workgroup, actually that's transposed. And then do a Q&A with council member advisors and the public discussion as well. Next slide. And then we'll move into discussing the CARE Act presentation. So hearing about, so we have California Health and Human Services Agency here today to talk to us about some of the different recent investments in behavioral health, including the CARE Act. So we'll be able to get an update on all of those efforts, and then followed by a focused discussion on CARE Act implementation strategies through the lens of our population of focus, which are individuals involved in with behavioral health needs who are justice system involved. And then we'll go over some announcements and next steps and adjourn for the day. So I think next slide, talking about, I think I'll be the one giving the diversion contract update. Thanks to my team. So as many of you may have recalled, we entered into a contract with the Council on State Governments Justice Center for a training and technical assistance contract to support the implementation and expansion of diversion in California. And we just recently extended the contract from, it was supposed to end on June 30th, and we've extended it to the end of the year. So it allows us for some additional time with the Council on State Governments Justice Center to do, to finish up some of the final activities. So thus far under the contract, the Council on State Governments did a survey to assess diversion implementation across the state and evaluate the needs for the training and technical assistance. They held six community learning sessions on the diversion training and technical assistance based on those survey results. And then they've held 3 topical work-through sessions to discuss diversion challenges. A few of the three main buckets for challenges that have come up through the discussions are access to substance use disorder services, housing, and insurance. So we've had some great discussions in those areas to really unpack the resources that are available and looking to really build that out within diversion programs or make some connections. And then finally, all of this information is going to roll into a final report on findings from the Council on State Governments Justice Center that we anticipate receiving in December of this year. That's the update on that. And next slide. So just opening it up to our council member advisors for any questions on our diversion project that we've been doing with the Council of State Governments. Okay, no, nothing. Okay. Any public comment or any questions from our participants today? Anything? No, nothing. Okay. Oh, we do have one from a 707 number. Okay. You're unmuted. Yeah, the number ending in 7133. Oh, hello.
Hi, Brenda. It's Kit Wall.
Oh, hey,
I
Kit.
was trying to get in on the link that you guys sent, and there was no way to unmute myself, and there was no chat box for me to pick up a link. So I just wanted you to know in case there's other people trying to get in. But I'm okay on phone. I'm cool.
Okay. All right. Sorry about that. Yeah, I don't know what was happening. We were having some technical difficulties. So I'll try to see if I could just send you a link, Kit, and we'll go from there. So thanks for letting us know.
But I'm on the phone. I'm on the phone. Thanks so much.
Thank you. Thanks for joining us.
Others are too. All righty.
Okay.
Bye-bye.
Thank you.
You know, I have one question.
Yes.
If I could ask it. Will we receive an interim report as to what they've accomplished and what their feelings are? I noticed that that in your little presentation, you said that one of the diversion challenges, which, since I do hear these cases, I'm very familiar with it, relates to substance abuse and treatment, as well as housing. I think it would be really helpful to get an interim update as to where what they've found thus far. I know I participated in one of the work groups, and it seemed to me that it would be really helpful if we knew, are we getting good attendance, and particularly because there's pending legislation relating to diversion. And so I just think it would be very helpful if they're able to do that.
Okay. We don't have any interim report. I mean, it's July and they're looking to have the report by the end of the year. But if there's things that we can pull out and, put out or sooner, we can circle back to them and ask.
Maybe I can be more specific. It would be really nice, helpful, I think, if they could identify the problem areas that they're seeing, that the judges or treatment or whoever is having, and so that at least we know what they are.
Thank you. Oh, can folks
Well, we
go on
definitely
mute?
have progress reports.
Yeah, we can look into that.
So,
Thank you. That's all.
Thanks.
and
Okay. All right, shall we move
Brenda?
on to, oh, yes.
Did you
this?
want me to go? This is Liz.
Oh, hey, Liz.
Hi, did you want me to mention that we do have progress reports related to this contract, and so I can go through them and try and identify the information that Judge Manley has brought up, so that we can try and give an update on that.
Thank you.
Thanks, Liz.
Sure.
Sorry, I didn't know you were talking, Liz. I heard. I thought you had accidentally unmuted because it was staticky. So sorry
Yeah,
about
I
that.
heard some other. I had heard some other sounds as well. So thank you.
Okay. Thank you. Okay. All right. So without further ado, next slide for my team, for our team. Big welcome to the Department of State Hospitals today to talk about the Incompetent Stand Trial Solutions budget. So joining us today is Chris Edens, who's Chief Deputy Director at the Department of State Hospitals. We have Stacy Camacho, also Deputy Director, and Dr. Melanie Scott, Assistant Deputy Director, Ashley Brett, Section Chief for Diversion and Community Restoration, and Dr. Sean Evans, Senior Psychologist Supervisor for Clinical Operations at the Department of State Hospitals. So thank you all for coming here today and sharing all this recent information, hot off the press information with us. And so we as a council can think about it through our lens of our population and, have a better understanding of the work that you all have been doing and will be embarking upon. So with that, I'll turn it over to you, Chris.
Yeah,
Thank
sure.
you.
Thank you. Thanks so much, Brenda. Thanks for inviting us here to talk about the IST Solutions budget proposal that was approved beginning with the 22-23 budget. And I'm not here to talk about the nitty-gritty details of the budget. That's actually for my team. But what I will share with you is just some of the activities and research, just hit it kind of at the high level, that led up to the development of this, what we are considering is a very historic budget augmentation for the department. By sort of at full implementation, we will have just over 600 million annually appropriated to support this this effort. And so it is a very exciting, unprecedented budget augmentation for us. So, and recognizing that we only have 30 minutes, I will kind of hit the high points and then turn it over to my team. So thank you. Next slide, please. All right, so just to kind of frame this up a little bit, in last year's budget, Health and Human Services Agency and the Department of State Hospitals were tasked with convening a statewide work group, and that statewide work group was represented by multiple state, local representation, as well as advocates and family members who participated in this work group. Very time limited work group convened between August and November of last year. And we were tasked with identifying solutions and strategies, short-term, medium-term, and long-term solutions and strategies to tackling the felony IST crisis. And I'll talk a little bit about why we consider it to be a crisis, but by and large, we have a number of individuals that are waiting a very long time in the jail, waiting to access treatment to restore their competency. And so we really needed to tackle this issue head on with a variety of perspectives. And we did that. We accomplished that. We, by November 30th, had completed a report that contained 41 different strategies and solutions, that of which the department had put forward at the time of governor's budget. 16 of the 41 strategies and solutions were packaged together in what we call our IST Solutions budget proposal. By May revision, we actually added a couple of additional strategies. So I think we're now at 18 versus 16. And I checked the link. The link is on the slides. It's available in the meeting materials today. So if anybody is interested in reviewing the report, you can access it through the link there. We also have all of the various meeting materials that were discussed during that few months late last year. Next slide, please. So this is just to share with you a few of the work group goals. We did have kind of overarching guidelines, but these were our main goals. And for the Department of State Hospitals, it's not just about reducing the number of individuals who are determined and sent to the department as incompetent to stand trial on felony charges, but it's also helping to identify and broaden the number of treatment options that are available for placement and for treatment. But the second bullet there, I think, and the first bullet are sort of at the heart of all of this, which is we want to really break the cycle of criminalization, which we believe wholeheartedly the conditions that folks are living in and sort of an unsheltered, homeless condition, and an untreated with their serious mental illness, untreated, that those are reasons that are sort of leading people into interactions with law enforcement, ultimately getting folks arrested and getting them thrown into jail. So we want to ultimately try to break the cycle of criminalization and improve the lives of the individuals that we are serving. Next slide, please. Next slide. It's not moving. Oh, oops. I think that's a few slides back. All right. It
Pull
should
the
be
slides back up again.
Okay, thank you. So I guess I'll just talk a little bit about beyond the work group, some of the pressures that were leading to the requirement to convene this work group is that, we've been really tracking the rate of felony ISTs for the last 10 years. Hold on one second. We should be at the slide, pressures to leading to the work group. Couple more back. There we go. All right. And so we've been tracking the rate of felony IST commitments being referred to the department for the last decade or so. And year over year, we've been seeing significant increases in the rate of referrals. And as of February 2022, unfortunately, that wait list was well over 1,900 individuals. I checked the wait list as of this week, and we're down to just over 1,700. So made a little bit of a dent in the wait list, but there's still much more to go there. And then in response to this increasing rate of IST referrals, we did a number of different things over the years, primarily looking in our own sort of backyard. Can we, exhaust every available bed within our state hospital system, which we did, hundreds of beds over the last decade that we've activated. And then look to, well, individuals are waiting in jail. Can we partner with the sheriffs through the establishment and implementation of jail-based competency treatment programs? That was primarily where we had focused a lot of our attention in the last several years to deliver treatment in jail because we ran out of capacity. And so currently we've got, I believe we partner with 21 or 22 counties currently for hundreds of jail-based competency treatment beds. And so overall, through the last fiscal year, we've activated nearly 1,400 new beds for IST treatment. But yet, no matter what we're doing, the rate of referrals, IST referrals, continue to outpace the number of brand new beds that we are establishing across the state. In addition to bed capacity, we looked at different system-wide improvements. So we've created efficiencies in the way we deliver treatment. We've reduced the average length of stay. by, I think, dozens of days. We established a patient management unit to really centralize, create efficiencies in how we're processing paperwork. And that has also created and reduced the timelines by which we are tracking individuals being referred by the courts into the department. And then we've also proposed and implemented a number of legislative changes also to help us create some efficiencies in our system. And then last but not least, the major sort of pressure point for us is this lawsuit that was brought about by the ACLU, again, because of the significant wait times for individuals who are incompetent to stand trial, waiting to access competency restoration services. And so after a number of years in litigation, that case has now been settled, and the department is required to deliver what we call substantive treatment, to commence substantive treatment to individuals who are incompetent to stand trial on felony charges within 28 days of being committed to the Department of State Hospitals. And that is a very short window of time. And I had not looked at the most recent stats, but the last stat that I had looked at had indicated our wait times were roughly in the 140-day to 160-day range. So we got a long way to go. Next slide, please. So the next slide is who are felony ICs. This is just to talk a little bit about the research that we have done on this group of individuals. We've partnered, our department has partnered with UC Davis for the last 15 to 20 years. And so we've studied the individuals who are IST coming in and being admitted into our state hospitals. By and large, these are individuals with serious mental illness. Our research indicates that approximately 70% of individuals who are IST being admitted into our state hospitals have one of three primary mental health diagnoses, and that's schizophrenia, schizoaffective disorder, and bipolar disorder. And so these are very highly treatable mental disorders, highly treatable, the primary intervention being medication. These are obviously individuals who have been accused of felony crimes. The state, just as a caveat, the state and therefore the Department of State Hospitals is responsible for those that have been charged with a felony crime. Misdemeanors are the responsibility at the county level. So really, we're only treating individuals who have those felony charges. But these are folks that have some difficulty in understanding their charges, may not be able to work effectively with their defense attorney, and so through an evaluation may be deemed and recommended as incompetent. The courts make that determination ultimately and order that IST. Also, through our research, we've identified that the majority of individuals, about 50% of the individuals that are coming into our state hospitals are actually unsheltered homeless at the time of their arrest. When you look at all homelessness, it's over 65% of the IST individuals admitted into our hospitals are experiencing homelessness at the time of arrest. So that's sheltered and unsheltered. We also partnered in the last couple of years, partnered with Department of Healthcare Services to do some data matching with our IST data set, and had found that, again, about 47% of the individuals being admitted into our hospitals had not accessed any Medi-Cal specialty mental health services in the 6 months prior to their arrest. If there were any sort of Medi-Cal activity within that 6 months, it by and large was emergency room services in community hospitals. And then in addition, nearly half of the folks that are admitted as IST into the state hospitals have had at least 15 or more prior arrests prior to the ultimate felony IST finding and what led them to their commitment to the department. Next slide, please. So this is an interesting slide that we like to share. We did some data matching with the Department of Justice, again, with our IST data set. And this is a few years back, mind you. But we wanted to find out, well, what happens to folks after we have treated them in the Department of State hospitals? What happens? Because just to give you a little bit of background for those that don't know, is that when folks are incompetent to stand trial, they're coming to the Department of State Hospital. They're only coming for restoration services. So that doesn't mean long-term comprehensive mental health treatment. This means what is it going to take to stabilize the individual and get them on the path to understanding what their charges are and working with their attorney. And so that looks very different than a sort of comprehensive long-term mental health treatment. So when we're treating someone, our length of stay in a state hospital is, for an individual who's incompetent to stand trial, maybe around, on average, about 140 days. The majority of folks are in and out of our system within 60 days. They come in, they receive treatment. Again, by and large, that primary intervention is medication. And we send them right back to the county, back to jail where they had originally come from. And so through our data matching effort with DOJ, some of the outcomes that we were able to track is that over 75% actually remain at the county level. 26% ultimately have their charges dropped, or they're dismissed or they're acquitted. Some folks end up serving, a probation sentence, and others serve a jail sentence. And less than approximately 24% actually stay at the state level. Either they are incarcerated through Department of Corrections, or they may be deemed not guilty by reason of insanity, and then they come back to the Department of State Hospital. But you can see with NGI, that's 0.2%, right? And then I also want to throw out another little stat, is that we also looked at kind of the what people think of as those really tough crimes, those crimes that are exclusionary from participation and diversion. Less than 10% of felony ISTs that are coming into the department have been charged with murder, rape, or pedophilia. Less than 10% of those folks. So I just wanted to kind of share that stat. By and large, you're looking at mostly assault and battery is the majority of the felony charges for this population. And then that last bullet is pretty staggering, that we've tracked that over 70% of at least the ISTs within our data set, 3 years post their IST commitment and release from, DSH, there was that they had recidivated. And that definition of recidivism really is just based on arrests, not necessarily convictions. So next slide. This is our hypothesis. Our wonderful medical director, Dr. Kate Warburton, has been sharing this hypothesis far and wide, but we believe that individuals with the schizophrenia spectrum disorders are really drifting into untreated, unsheltered conditions. These are the conditions that are leading to increased contact with police and ultimately landing them with some criminal charges, and that this increased contact is directly correlated with a surge in the IST referrals that are coming to the Department of State hospitals. And so, we believe building more state hospital beds will only exacerbate that problem long term. I mean, we've demonstrated over the last decade, again, nearly over 1,000 beds. And the more we build, the more ISTs come our way. And ultimately, as you can see from with this next bullet and referring to our last slide, IST restoration is not adequate long-term treatment. It's not the solution. So what can we do? Next slide, please. This is a very cool graph that some folks, very smart people in our department came up with, but this is sort of our vision. We want to break the cycle of criminalization, right? Based on some of those stats that I kind of thrown out, majority of the folks that are coming in are homeless. They're getting arrested, they're incarcerated, they're coming to some sort of state hospital treatment, whether that might be in jail or in one of our state hospitals. Ultimately, majority are going right back to the county and right back to the conditions in which it precipitated sort of the conditions that led to their arrest. And then people are being re-arrested, years later. And so we want to kind of break that. And that is ultimately the foundation of what led us to some of the solutions that we have been working towards in the last few years, which our DSH team will talk through some of the budget items soon. But just to share in the next few slides, which I'm not going to really read through, but slides 9, 10, and 11 provide a really sort of high-level summary and recap of the various strategies and solutions that the IST Solutions Workgroup had identified and that are available in the report. And many of these bulleted solutions are ultimately what was packaged up into our comprehensive IST budget proposal. So with that, if you wouldn't mind just scrolling through to, I think, slide 12. Perfect. I will hand it over to either Ms. Ashley Breath or Ms. Stacy Camacho to take over the next slide. So thank you.
Hi, everybody. This is Ashley Breath from Department of State Hospitals. If we could go to the next slide, please. So Stacy and I are going to kind of share this slide. These are just a summary of some of our past IST solutions or efforts that have been funded in prior budgets that really feed into the work that we're doing through the IST Solutions budget proposal. And the first 3 bullets fall under me. So we, of course, have our IST Diversion pilot program and the expansion that was funded this past fiscal year of that program. So just really quickly, we are entering into our 5th year of this pilot, and we have about 3 more years to go before all of our county programs get through the full length of their pilot programs. The state has invested approximately $128.5 million in this initial pilot program with some additional housing money that I'll speak about in a moment. We are working with over half of the counties in the state, and through those contracts, the counties have agreed to attempt to serve approximately 1,000 clients through these diversion programs. As of December 31st of 2021, which is the most recent data set we have, our data collection, we have a bit of a time lag in our data collection with the counties, but as of the end of this past calendar year, the counties had admitted 609 individuals into their diversion programs, 70 of whom came from our DSH waitlist. And then as an additional investment this past spring, as a result of some of the conversations that happened through the IST Solutions Workgroup, the department allocated an additional $48 million in supplemental housing funds to the counties that we are contracted with. Counties could elect to take up our offer of that funding, and we have allocated all of those funds out to counties to supplement the increased housing costs of this population. But we did specify that the funding, this is supplemental housing funding, could only be used to support felony ISTs who were diverted from the DSH waitlist. The next program that we've had running for about the same amount of time as the diversion program is our community-based restoration program. We've been running a pilot in LA County. We're going into our 5th year there. And as of this past week, that program has admitted over 1,000 felony ISTs into the treatment program, which is very exciting. We've had funding to expand that program statewide, and we have been in preliminary conversations with a number of counties over the past 12 months. And we will be ramping that up as we move into implementing our IST solutions budget. And then finally, we have our IST, IMD, and acute capacity funding program. So this is a funding program where we received $250 million in last year's budget, plus ongoing program funding to support the creation of new IMD capacity across the state. Really, we see these as an opportunity to fill a void in the continuum of care out in the community. And our ultimate vision for this is that these will serve as step down options for counties as they are transitioning folks from jail into one of their community-based treatment programs. So if that individual needs extra stabilization, this would be an option for them. And then also as a step up from the community programs, if somebody has destabilized and needs some extra services in order to remain within those community programs. We're following or working with a number of different providers across the state to set up these programs, and we did activate our first program through this funding opportunity this past April. We partnered with a brand new acute psychiatric hospital in Sacramento County. We are contracted to use up to 117 acute psychiatric beds in that facility. They began admitting patients in April, and our current census is standing now at 36. And those are ISTs from across the state that are being served in that facility right now. And I will hand it off to Stacy.
Thanks so much, Ashley. Good afternoon. So these next few investments, I just want to run through them. In last year's budget, DSH implemented the IST Reevaluation Services Program. So it's a statewide service to reassess IST defendants that are on the wait list. And as of this month, we're contracted with 25 counties, but we're actually performing the reevaluations in, I believe the last count was 54 counties. And really what that means contractually is that there's a mechanism to reimburse for technology fees, as well as the staffing and other resources related that the jails impacted on their end. So that could be record pulling or escorting individuals for the evaluation. And in our conditional release program, in building out a greater continuum of care, there's a couple different programs. Most recently, our Forensic Assertive Community Treatment Program. So at full activation, it will be a total of 180 beds. It's spread across 3 regions, so centralized in Sacramento and San Diego, as well as a future Bay Area activation. And our Sacramento and San Diego programs activated earlier this calendar year. Very exciting. They also serve clients statewide. And then we are anticipating our Bay Area location to activate later this fall. And again, continuing to build out the continuum of care so that we have options for individuals that are ready for discharge from the state hospitals and to step down into a lower level of care, but also are not quite ready for maybe a typical conditional release environment like a board and care or room and board. We're creating more options for a higher level need. So the first program, or I shouldn't say first program, but a recently activated program is our 30-bed statewide transitional residential program in Northern California that activated in the spring. And we've already begun admissions and working towards filling all of those beds. And later on this calendar year, we're anticipating a 78-bed, we call it a step-down program, but a 78-bed IMD program that'll activate in Southern California. And next slide, and I'll hand it back to you, Ashley.
Sure. So moving into our IST Solutions Proposal, In this past Budget Act, the department has received in total $592 million in new funding to support the rollout of the proposals that we're going to discuss today. And this is the dollar amount for full implementation. So we do have a 4-year ramp up timeline. So when we get to that full implementation, that's the investment that the state has made. There's two kind of main components or pieces to this proposal. One is the early access to treatment and care coordination programs, and then our diversion and CBR expansion. We also included a link to our May revision binder if you want to dig into the nitty-gritty details of the proposal itself. That link will take you to that document. So we can move to the next slide, please.
Okay. And so as Ashley mentioned, there's really two main components that our IST solutions, if we were to bucketize them, fall into. And really the front end of our IST solutions are our early access to treatment and care coordination by way of what we're calling an early access and stabilization services program, and then a care coordination team to accompany that. So really the goal there with this program is to provide immediate solutions to support access to treatment for those individuals that have been found IST and are waiting in jail. They're pending placement to a DSH bed. So the components of our early access program are to provide timely mental health, psychiatric stabilization, and competency restoration services, as well as that increased clinical engagement. And so we see this as a complement to the foundational mental health treatment that's already occurring in the county jails, but above that baseline level. So components of the program include funding for psychiatric medication support by way of long-acting injectable funding. Treatment is facilitated through partnerships with private providers. And so, like I mentioned, in collaboration with the foundational jail mental health providers, we're looking to roll out programs in all 58 counties in the county jails. If you're familiar with our jail-based competency treatment programs, we see this as kind of a front end of those counties that have programs, but really is meant to engage the individuals as quickly as possible upon referral to DSH. And funding received in the budget was just under $25 million in this past fiscal year, and then $104 million this fiscal year and ongoing. A piece of that is the case coordination teams. So we were establishing a case management team and care coordinators to really facilitate appropriate treatment and placement of the individuals and really make sure that the IST defendants are followed through their IST pathway. So I think that what we would really hope out of this program, our ultimate goal is we would love for stabilization and then step down into a diversion program or community-based restoration. But sometimes that pathway might also lead that individual to a jail-based competency treatment program or onto a state hospital. So the care coordination teams will make sure that there's someone there following along, making sure that we have appropriate services for those individuals. And I will pass it back to you, Ashley. Next slide, please.
Thanks, Stacy. So the second piece of our proposal is, we're calling it the expansion of diversion and CBR, but what it really is the transition out of the diversion pilot into a permanent ongoing program for diversion and CBR funded by the state. And so some major parts of this, we are not only going to be offering permanent ongoing funding for diversion and community-based restoration, but we are hoping to expand the scope within the community. Our goal is to, by the time we get to that 4th year of implementation, have enough capacity within the system to admit 3,000 new felony ISTs into that system of care each year. In order to do that, there has to be a place to put people to receive the treatment. And so DSH was given, and I am going to apologize, there is an incorrect number here, and I will send a corrected slide deck to CCJBH after today's meeting. We were actually allocated $468.8 million in residential infrastructure funding to build out up to 5,000 beds across the state to serve the 3,000 ISTs that our goal is to admit each year into this level of care. As I mentioned, this will be permanent ongoing program funding for the counties. One other major change to this program that I do want to point out is that we are no longer going to, in this permanent program, provide funding for services for the likely to be IST population, which was a population that we have been, that counties can provide services to through our current diversion pilot. We can go to the next slide, please. So here you'll see once we get to that full implementation phase, the state has invested on an ongoing annual basis $507.5 million to support these programs across the state. So this is going to include per patient budgeted funding for all of the wraparound treatment services that are necessary to support somebody in a program like this, as well as quite a bit of funding to support all of the non-treatment costs and activities that that take place in the county in order to run these types of programs. We included funding for things such as county administrative overhead, the support of using risk assessments during the evaluation process. We included funding for what we're calling court liaison positions, which would be a clinical position that could help advise the court on the treatment options available for a felony IST within a particular county if the court is considering different placement types. We also have included for all counties, regardless of whether or not they contract with us for diversion or a CBR program, $100,000 annually to support the work of stakeholder work groups within the communities. A lot of counties already have these established, but these are the work groups that bring together partners from behavioral health and criminal justice to find local solutions to the issues of individuals with serious mental illness falling into the criminal justice system. And then we also have quite a bit of funding included in this budget to continue building out our robust technical assistance and training programs that we provide to the counties to help them implement, establish, activate, and keep these programs up and running. Next slide, please. So another new change that is part of this solution package is our Felony Ist Growth Cap. So as Chris had mentioned, over the past decade or so, IST referrals to Department of State hospitals have been growing exponentially. And so as part of the large investment that the state has made in the IST Solutions budget package, we did include a county growth cap. So in short, the rate of referrals from counties in this past fiscal year has been the historic high of the years that we've been tracking this. So we will be using fiscal year 21-21 referrals as a baseline. And if counties exceed the number of referrals compared to that baseline year, and it's outlined in the statute what those specific markers are, the state will be providing, or not providing, but will be sending will be requesting penalty payments from the counties for those excess referrals in the year. Counties have the ability to select and pay those penalty payments from any county funding source that they deem appropriate. And what will happen is those funds will be collected into a new account and be redistributed and returned back to the county they were collected from. But those funds must be used by the county to invest in pre-arrest diversion programming and strategies. So next slide, please.
Okay, and I'll just run through the other solution investments. There's also funding in the IST Solutions package to partner with the Judicial Council to support a statewide training program. And that's for the county evaluators in order to improve the quality of the IST determinations and the medication decisions. There's also resources and funding to support IST discharge planning. So resources will support that coordination between DSH and county behavioral health, what we're calling kind of a warm handoff of ISTs. And then we're also piloting a ConRep independent placement panel, looking to increase the number of placements of our not guilty by reason of insanity and offenders with mental health disorder patients that are discharging from the state hospitals and would be admitted into ConRep programs. Thereby allowing us to backfill those vacated hospital beds to serve ISTs. And I believe that's the end of our slides. We're happy to answer any questions, though.
It is. Thank you so much. What a ton of information and a lot of work that has to be done. So thank you so much for all that information. I'm looking at the time right now. It's 4 o'clock, so we have an hour left and we still have Stephanie's presentation. Are you guys able to stay, or do you guys, I'm looking at the DISH team. So if you guys are able to stay, maybe we can push through, do care court, and then do full questions. Would that be okay for our council member advisors, or do you guys want to do some questions right now?
I'm happy to stay.
Whatever will work
Okay.
best.
Judge, do you have any preference? No preference?
No preference.
Okay,
I think we should hear the other presentation.
Yep, okay, just want to
in
make sure
light
that
of
we
the time.
cover all the great grounds. Okay, thank you, everybody. All right, so with that, we'll turn over just to, thank you so much. A couple of slides forward to our next presentation on the CARE Act, SB 1338, with our very own Stephanie Welch, who was our former executive officer. Great to have you back and in this new role. And oh, Mark, the copy of the slides is online. So can somebody put the link for Mark to the slides? Thanks for asking the question. So with that, I will welcome our Deputy Secretary for Behavioral Health at the California Health and Human Services Agency, Stephanie Welch.
Oh, thanks. You know, I was going to ask, should I go up there? Would it be helpful? I can't see very well. I might not be able to see the screen.
Oh, okay. Well,
but I think we're going to maybe,
want to see my?
look, Chris is going to help me out here.
Okay.
Then I can sit up with you guys.
You can have my computer too.
Perfect. Okay, thank you. And actually, if it's okay with Chris, I'm going to take this off while I'm talking. Okay. So hi, it's nice to be here. I'm surprised that this is the first time I've been back in 2 years. So, but it's really nice. And it's been a joy to go over to agency and work on many of these issues. Can I make one comment about Chris's presentation? Just if I don't get a chance to make it again, it is related to care court, but the opportunity to have that ongoing $100,000 locally for justice coordination is something I hear all the time, not necessarily related to the planning that's going to have to be put in place in order to implement care, but also to roll out the CalAIM justice package. And so since we are going to talk a little bit about ways in which I think the council and your stakeholders and constituents could be constructive and helpful with all of these major initiatives, is really thinking about how do we support our local partners in having functional, strong collaboratives that can really help them implement some of these significant policy changes at the local level when it comes to addressing the needs of the justice-involved population. So just a little shameless plug there since I have the mic, but thank you. Okay, so I'm here to talk about the CARE Act, yes, SB 1338 as proposed. And and next slide, I keep forgetting I'm not moving the slides, sorry. I think it's really important, and it's nice to go after the Department of State Hospitals because you see the significant investment that the administration and the legislature has made in addressing some of the root causes of this particular crisis. But we really are in the beginning stages of several very significant systemic changes to how behavioral health care is delivered here in California. And with that, there's also needs to be a recognition that these are critical investments that are being made to a system that is structurally and for decades underfunded. And I think we all would agree that that's really driven by stigma, and that it has been fairly recent that mental health and substance use treatment has been seen as something that should be provided at parity as other treatment for other physical health and medical conditions. I would say that not even everybody necessarily even agrees with that, but that's where we're going. And so we are going to talk about the fact that we know that we have a very fragmented system, and that we know that we have an under-resourced infrastructure for this care for Californians, but that over time we feel really confident that we're going to build a system that's going to be able to serve everyone. So and I'm sure you guys are familiar with this. You probably have had a presentation in the past from the Department of Healthcare Services, but the department in collaboration with implementers and stakeholders conducted a pretty significant behavioral health needs assessment as we were in the midst of getting ready to really implement some of these significant changes and to roll out new resources. And there were a couple of things that were really telling that came out of that report. One was that there seemed to be a lack of a comprehensive approach to crisis services, that on a county by county or community by community basis, there was a very different array of what was available for somebody who was in crisis. As you guys have talked about, for many years, there is a dearth of community-based living options for people who specifically have more serious behavioral health conditions. There are in the state very, very few treatment options for children and youth, specifically and probably more likely with substance use disorder conditions than with mental health conditions. And that there were clear disparities in access to services or overrepresentation in services amongst certain ethnic groups. And lastly, something that you have championed as a message for a long time here at the council, for those who are justice involved, everything is a lot harder in terms of securing housing, securing physical and behavioral health care, and economic security. Next slide. So we have had a cycle of the last 2 years of being pretty much one of the top priorities of this administration when it comes to budget investments. And you just heard about one of them. I think I don't know if you guys get as stunned as I do, but having $600 million going into the state hospital system to divert people from institutionalization is a really exciting thing to champion. And I'm proud to be part of an administration that is putting its money where its mouth is. But there have been many other things, and I'm not going to go through these because I know you guys want to talk about Care Court, but the landscape is large. So first of all, there's the CalAIM Justice Package. Obviously, the Children and Youth Behavioral Health Initiative, which is inclusive of trying to find ways to prevent young people from being involved in the justice system due to untreated mental health conditions or substance use disorders. There is the Behavioral Health Continuum Infrastructure Program, as well as the Community Care Expansion Program. One is more focused on facilities and places where you can go to get treatment and services, while the other is really focused on adult residential treatment facilities that are serving individuals who are living on SSI or who are otherwise in vulnerable states, which would certainly be the population we're going to talk about today. We are in the midst of launching our new peer support services benefit in Medi-Cal. We have ramped up and will continue to ramp up more mental health parity enforcement investigations, making sure that individuals who are not part of the specialty mental health system are getting treatment for their mild to moderate conditions to prevent them from having more severe illness. We've established an Office of Suicide Prevention. Our agency is in the midst of doing some comprehensive crisis care continuum planning. We have continued to invest significantly in CalHope, which is a crisis counseling assistance program and training program. And we are also in the midst of preparing to plan for the implementation of the 988 rollout. We are expanding medicated assisted treatment. We talked about the incompetent to stand trial. Some of our budget efforts this year really build on last year, once again, really focusing on some of the populations that this council is charged with providing guidance on. So we are putting out resources for the infrastructure component of our building out our Medi-Cal community-based mobile crisis system. We are using PATH funds, providing access and transforming health, to really focus on further developing our enhanced care management and community support systems of care in CalAIM. And recognizing that we need to dedicate additional resources to ensure that those providers have the capacity to serve justice-involved individuals. And just a significant number of things. Oh, I'm sorry, I didn't say move the slide forward. Apologize. Next slide. Next slide. I forgot. I'm moving it over here and I totally forgot it's not moving up there. And then with the opioid settlement, as well as still utilizing funds from our federal coronavirus relief funds, we've been able to really invest in trying to get our arms around the overdose crisis, in particular the fentanyl overdose crisis, including that crisis that's impacting young people. So we're also investing, this is next slide, specific to Care Court. 1.5 billion was approved in this year's budget just a few weeks ago to develop behavioral health bridge housing, an area that I think we certainly could collaborate with this council on when we think about providing technical assistance to the counties on how to use those funds. That funding goes directly to county behavioral health. There's more information down there about the IST Solutions package. Next slide. We're almost done. This year, really excited about some of these initiatives. We were able to secure almost $300 million additionally to do a really robust youth suicide prevention and behavioral health access campaign. We have nearly $2 billion, even more if you count last year, to address the workforce shortages. Much of that is dedicated to people who work in the behavioral health space. And I can come back on another day, because if you guys have any ideas about what we could do sooner rather than later in that space, we're really, really struggling. And then lastly, obviously our Care Court numbers here, 64 million to implement the Care Court infrastructure. And I think when I get to talking about Care Court, next slide, I hope that one of the things I press upon today is that Care Court is really a mechanism and a process. It's not a program. So without further ado, jumping into Care Court. The Community Assisted Empowerment and Recovery Court is really a way that we have created a new pathway to access comprehensive treatment. CARE really aims to deliver behavioral health services to the most severely ill and vulnerable populations that we serve. And in doing so, preserve as much of the ability to give self-determination in that care, and to ensure that people are living in the least restrictive environment in the community. We see CARE obviously inspired by many of the staff and team at agency who worked so diligently on IST solutions, and I think became, to a certain extent, really frustrated that the only way to get access to the level of care that Chris and her team has described was to be deemed IST on a felony charge. And that just didn't seem appropriate when we knew that we could go upstream. At least when I say upstream, I mean with people who already have very, very serious untreated or undertreated mental health conditions, that we could do more. And so we wanted to make sure that we were designing a mechanism that really was aimed at preventing incarceration amongst this population and preventing institutionalization, including long-term conservatorships. So the other thing I think that's specifically different about CARE is that it really is not just about the participant being held accountable, which is much of the design of even, frankly, our mental health courts, but also very much so even on the civil side, our AOT courts, where it really is the individual who ultimately is being held accountable rather than the systems and the partners and the service partners who are charged and responsible with helping to serve that individual. And I think the other thing that's important is that care court is certainly not for everyone experiencing homelessness, and it's certainly not for everyone experiencing mental illness, considering that mental illness is a condition that people experience on a very, very broad continuum from mild to severe. And they have that experience oftentimes at different parts of their lives. And so I think we really tried to be mindful of that in how we propose the design of this. Next slide. So first, I'm going to just share a little bit about what is different about care court. We believe that care court is fundamentally different than LPS conservatorship because as much as there are definitely people who are conserved, who are living in the community, they're not living in necessarily locked settings. The reality is that most people are living in custodial settings and they're there for a very, very long period of time, including being on long-term involuntary medication orders. We also believe that care court is different than Laura's Law, or here in California, our assisted outpatient treatment program, in several important ways. One is the petition can be initiated to the court by a variety of people. The county specialty behavioral health system is not necessarily the gatekeeper of the petition process, which we felt would be more helpful in terms of facilitating the petition process, which I'll talk about in a moment. We really thought that it was important to design something that someone would be eligible for who didn't have to have multiple negative outcomes occur prior to being considered a candidate. So while there is some pretty strict criteria that we'll talk about in a minute, there is not the requirement to have multiple hospitalizations, multiple arrests in order to be qualified for the program. Also, local government systems are held to the same level of accountability as the individual, which is not the case in any of the other things that we have designed in this space. And lastly, this new concept of a supporter that is really assigned and chosen by the individual participating in care court to really help that individual attain the most independent decision-making and person-centered approach to their care treatment plan. So helping them with their care plan, helping them with their graduation plan, and if the individual so chooses, working with them to develop an advanced psychiatric directive. So the criteria for care, next slide. Person must be an adult, 18 years or older. The person is experiencing a severe mental illness and has a diagnosis of schizophrenia spectrum or other psychotic disorder. And I think that's really important. The and is very important for us. This means that if this person might be experiencing or displaying psychotic symptoms or behavior that might be associated with psychosis, but they do not have a severe mental illness, then it calls into question if they're the right candidate for care court. Doesn't mean that they're not, because we have other processes down the road that include a full clinical evaluation, but it is important to have both of those present. Of course, the person must not be in clinically stabilizing ongoing treatment. That care court would represent the least restrictive alternative. Again, we do think these people will be at high risk of institutionalization and high risk of incarceration. The person must benefit from care court proceedings, and the person meets one of the following. They're either unlikely to, I'm sorry, that's supposed to say unlikely to survive safely in the community, not service, I apologize, and that they need services and supports to prevent grave disability or serious harm. So I am going to, we're going to go to the next one. I'm going to take a little bit of time to go through this because I think when I talk to groups and I see how many questions they have, they're very much have questions about kind of the process, like how does this actually work? And so we're going to take some time to go over this because I think it's important. We were really working to be responsive to some input we've gotten from a variety of different stakeholders and constituencies, and that was really to try to create as many voluntary off-ramps to the eventual possibility of court-ordered treatment. And so that's what I'm going to walk you guys through today. So a petition is filed. It can be filed by a variety of people. You can read what's up there on the screen. Anything from county behavioral health to first responders to homeless outreach workers, tribal courts, etc. The petition is promptly reviewed by the court. And if it does not meet criteria, the person doesn't meet the criteria just outlined, then the court dismisses it. Nothing happens. If the petition merits the required criteria, the court in this June 30th edition of the amendments, the court then orders the county, and it is generically the county, but I would assume, and we would envision this would be county behavioral health, to investigate and file a written report within 21 days that includes a determination as to whether or not the respondent meets or is likely to meet the criteria for care proceedings, and the outcomes of any efforts that were made to voluntarily engage the respondent. I think for us, what we're trying to do here is be responsive to the comments we had that were there were so many of these individuals who, if offered high quality care, including housing, would accept it, that there really wasn't necessarily a need to pursue any kind of court-ordered care because with the right engagement and the right offering of help, that help would be accepted. So that is responsive to that. And then the next phase, so the county agency after this 21-day period can submit a report providing any conclusions that they had in that investigation along with recommendations. The county also has the opportunity for 30 more days to continue to do engagement if they are hopeful that the individual will voluntarily enroll in services. Next slide. So after now the petition is kind of active, there is a thought that there needs to be kind of confirmation that this is an individual who meets the criteria for care court. So the court, after receiving that report within 5 days, in reviewing the report, will either say that this respondent meets or is likely to meet the criteria, therefore voluntary engagement is effective. The court simply dismisses the matter. It doesn't go any further. If the court determines that the respondent meets or is likely to meet the criteria and engagement is not effective, the court will set an initial hearing within 14 days. And that did not exist before, so I'm just making sure that everyone knows that that is a new element to the care proceedings. So now we're moving forward with the individual who the petition has been filed. They're not, the county has been sent out to do engagement and the individual does not want to engage in services. So the hearing is taking place. And at the initial hearing, the court determines if there's an appropriate evidence that the respondent meets the care criteria. And all of the parties are there. I'm not going to go through and read all the parties who are there at the court. The court then orders the county behavioral health agency to work with the respondent, the respondent's counsel, the care supporter, and to engage in behavioral health treatment. And then there'll be a case management hearing in another 14 days. Next slide. At that particular case management conference, if the court finds that the parties have agreed to a care agreement, and basically that's a care plan that doesn't require any court orders. It's basically another form or opportunity for a voluntary exit from the care proceedings. They do set a progress hearing within 60 days because they want to make sure that the county and the individual were able to follow up and start to really implement that care agreement. If the court finds that the parties cannot reach a care agreement, the court shall order a clinical evaluation of the respondent, and the evaluation shall address a clinical diagnosis and shall also assess whether or not the defendant has the capacity to give informed consent regarding psychotropic medications. I think pointing out here, again, until that clinical evaluation is ordered by the court, as you can tell, the whole process up to now, and actually continuing after now, the individual at any time can walk away or not proceed or not participate in any of this. So the clinical evaluation that is ordered is going to be conducted through county behavioral health by a licensed behavioral health professional, and it must take place and be done within 30 days. And after it's done, the hearing will take place within 14 days. Next slide. If the clinical evaluation comes back and finds clear and convincing evidence that this individual does meet the care criteria, then the court will order the county behavioral health, the participant, the supporter, the counsel, etc., to develop a care plan. If this person does not meet the criteria, the whole order is dismissed. The care plan is developed as a collaboration between the respondent, the supporter, counsel, and county behavioral health. And in reviewing the care plan, the court may issue any orders necessary to support the respondent in accessing appropriate services, including the prioritization of those services and supports. In issuing the approved care plan, this starts the 1-year timeline. Care is 1 year long. And I don't want to, I just said that this wasn't a program, and it says right there on my slide, so I'll have to fix that. Next slide. In the 11th month of the program, there is a process to determine if the respondent graduates, if the respondent voluntarily wants to be reappointed, is this person ready to leave care? That all takes place in the 11th month, so that by the 12th month, the individual can have their graduation plan, which is basically a transition plan to ongoing services and supports that are appropriate for that individual. If at any point in time that I've kind of talked about, between the very initial engagement to all the way down, from the court-ordered clinical evaluation all the way till the 11th month, an individual is, actually, I'm skipping ahead. I apologize. This is important for you guys. The judge in the court has the authority to refer somebody who's in an AOT program to care court. They're both civil processes, or somebody who's currently going through conservatorship proceedings. Again, we still feel like the level of care and treatment in a program that is under the kind of care umbrella would in many cases be appropriate for somebody who is at a conservatorship level of care. And for those individuals who are in the middle of misdemeanor proceedings, they can also be petitioned to be sent to care court. So actually removing them from criminal proceedings altogether to civil proceedings. So on the next slide, on the individual accountability, if the court determines at any time during the proceedings that there's an individual who's not participating, they may terminate their participation in the care program. This is the person who never shows up. It's not the appropriate fit. That's within the discretion of the court. The court may also utilize existing authority to ensure an individual's safety. To do that, they can utilize at their disposal existing authorities under LPS if somebody is in need of an involuntary hold. But there's nothing that we're doing to change the criteria for somebody who would meet that threshold. And we are asking that if that is the case, then the court notify the public conservator or guardian that that they are doing this. In addition, if the care not completing care court, excuse me, can serve as a factual presumption that no suitable community alternative is available to treat an individual. So if this individual is going through conservatorship hearings, that would be evidence to show that they have no other suitable community alternative. Accountability on the county and local government is that the court has the authority to fine a county or the local government entity if they're not complying with care. The fines that will be collected will be used to establish the CARE Act Accountability Fund. The law currently states that all monies in the fund shall be used upon appropriation through the Department of State, Department of State Hospitals, Department of Healthcare Services to support local efforts to serve individuals who have schizophrenia or other psychotic disorders. So basically to serve the same target population that the CARE Court is targeting. So we have been having lots of conversations at this point. I'm glad that I'm here because we're still in the process. We have another round of amendments we're working on at this very moment. And we've been having lots of conversations. I think some of the things that are in this list we've tried to address in recent amendments. So opportunity for earlier services, voluntary services should it be offered to really strengthen the supporter role, making sure that peer support is also in addition to and part of the ongoing care plan, that we are promoting and using trauma-informed policies and addressing racial bias. We required both of those things in the TA package that was written into the last set of the bill. That more needs to be done to ensure that housing resources are available, and that even though we're making significant investments in the behavioral health continuum, including buildings and workforce, it's not enough, fast enough. And there are concerns that we have to slow down or speed up, which is what my speed up my presentation. Okay. So here's a quick summary of the key changes in the most recent version of the bill. Which dropped on June 30th. So I think a lot of people might have missed it. So as I mentioned, the court directed county engagement process to encourage voluntary participation in services. A two-phase phase-in approach where half of the counties implement in 2023 and the other half in the year following. We added some significant additional training that is optional that DHCS will be providing with initial implementation oversight of care remaining at agency, kind of get the thing off the ground. We have created legal representation from a local qualified legal service project. So that's your local legal aid services. Some of the thinking behind this was that legal aid is often advocating and supporting individuals with many of the same challenges as the care population. So helping them secure housing, deal with housing discrimination, employment discrimination. We really thought that it would bring some advocacy and representation to the individual's needs into the equation. Creates the accountability fund I just mentioned. There is both an external evaluation as well as ongoing robust care reporting, which I would encourage this group to look at closely to make sure that we got everything in there. And then an emphasis on addressing or promoting trauma-informed care and training around addressing racial bias. I don't know if we have time to go through these, Brenda. I think these last few slides at the end are really some of the main questions that we get. Yeah.
We can just have those for reference in case
Okay.
anybody wants them, if that's okay, just because it's already 4:30 and we can open up for questions and discussion, especially since it's both the DISH and CARE Act.
Got it.
conversation. So how about we move to the Q&A slide, and we'll open it up to council members, Chief Jenkins and Judge Manley, to ask questions. I've been seeing them jotting little notes along the way. So if one of you want to start with the questions.
I always defer to the court.
No, go
first.
ahead, Nav.
First, I want to go back to the dish presentation. Kristen, I just thought that was an exceptional presentation, by the way. It was really, really informative. On the slide where you were talking about what happens after IST treatment, and you broke out some percentages, and you actually answered one of my questions there. One of them, because you talked about treatment, and you said that primarily the treatment is medication, correct?
Yeah, that's our primary intervention. Yeah.
Understood. And then you later on made reference to, I don't know what the proper term is, but involuntary treatment. But my question is, what percentage of those receiving services are receiving the medication involuntarily?
Oh, that is a good question. That's not. I think we were asked that question once before, and that is not something we're able to discern, because oftentimes, even though someone may be issued an involuntary medication order by the court, we aren't necessarily forcibly medicating people. It is oftentimes hey, I have this involuntary medication order. I can enforce it if I need to, and often you get compliance, and that's
Understood.
just not a metric that we do track. And then obviously once someone is medicated, right, and they are at the point that they've stabilized, often are willing to and are then more actively engaged in taking their medication. So that isn't a metric that's easy to track.
Okay,
really.
you well explained the nuances, but
Yeah.
it is an area of interest. And then on that same slide, you mentioned the recidivism numbers, and you did talk about them as being, I forget how you described it, but my specific question is the metric there, rearrest or reconviction?
Well, we were tracking arrests, so
Okay.
rearrests.
It is
Yes,
rearrest.
not necessarily actual convictions. But one interesting other point there that I wanted to make on that piece of it, that we identified 70% had recidivated, meaning were rearrested at least 3 years, post IST commitment. Our only community-based restoration program that we have currently activated is in LA County. That's a 515-bed felony IST program. In the fall, they provided a presentation to the IST Solutions Workgroup, and at that point, they had tracked their recidivism rate for the individuals who had participated in the program, and at that point, it was a 17%. And that, I believe, was also rearrest. So, from 70 to 17%, which is why we, really believe in providing more community-based options for this population.
Okay, and I was just curious, do you have a sense of how many people that involves, that 71% after 3 years?
I don't have that data point off the top of my head, so I'm looking at the team. We could definitely get back to you.
Okay.
Not-
And then this other point on this is just a little bit of a comment, because you have made the point that the services are restorative by focus at this point. So in that sense, it doesn't surprise me that after that there would be a recidivism, even a high recidivism number, if the focus is on restoration to competency, as it were.
Yeah.
But and then there's if there's not the effort at that point, and this is not a criticism, it's just a comment, then it doesn't surprise me that there might relatively be a high recidivism rate if there isn't a handoff, as it were, into some other continuum of care of treatment. So,
Right.
so that I didn't was sure. I'm sorry.
Well, I was just wondering if I could just ask a quick question, because Mac's on this vein right now. But I was also wondering too, like, of the how the list has grown exponentially over the years. Has there been like a deduplication of it to see like how many people are truly new people, and then how many people are churning? Do you guys know that part of it? Is it the same people or not, or is it?
We have tracked that, and again, I I'm looking at the team to see if anybody has that metric. I don't remember what percentage we had tracked of individuals who've come back into our system. I can
Or even
follow
who
up with
go
that.
felony ISTs, I'm like, is it, the 80% of the people are just, the same people, or is it something like 10% of the people are the same people? Like, just to get an idea of the magnitude of, like, is it just a handful of people that are just needing this level of care? Or,
Yes.
yeah.
I don't think it's that high. I don't think it's as high as,
Mhm.
50
Yeah,
to
yeah.
80%. I do think it is a lower
Mostly new
percentage.
people.
Mhm.
Mostly new people. Yeah.
I believe it is mostly, at least within the data set that we've been able to follow up on, but I'll make a note of that as well.
I just have one more and then one for Stephanie, then I'll give it to the judge. But I forget which one of your staff covered the slide that talked about 468 million, I think it was, for residential infrastructure investment. Is that an accurate figure?
Yes, 468.8.
Okay, and you may well have addressed this question later on in the slide, but I'm not sure. Is that 468 million hard construction dollars, or does it also include staff and programming and services?
So that is the infrastructure, the hard construction, remodeling, purchase of, the idea is that you would purchase a residential, a house and remodel it and have, we budgeted at about 8 beds, 8 units, or 8 beds per, housing structure. But that is the funds to build and activate those beds. The services would be paid for through the $500+ million that we will be providing to the
Right.
counties to have diversion and CPR programs.
Thank you. That's just what I was asking. And Stephanie, I have a million questions on Care Court, but I'm only allowed to ask one.
You go ahead, man.
No, but
I've asked all my.
But one of them that jumped out to me, and you may have touched on it, I'm just sorry if I missed it, but is the respondent represented?
Yes.
And who is that at the public defender's office, or who are they represented by?
They're represented by legal aid services. That change was done in the June 30th amendments.
Okay.
And again, the thought there was that legal aid is doing a lot of this work with these clients. And since obviously we're behavioral health, so we're going to talk about the role that behavioral health services play in serving the care court participant. But there's a lot of other social welfare and housing services that we want this person to get. And we were thinking that legal aid would be a good entity to work with.
Okay.
And I think we really were trying to make sure that the court process was minimal and that we tried to create the most trauma-informed practices so that the individual would have potentially minimal time in court. And so that was some of the thinking behind it. I can be very honest with you in saying there's a lot of people who do not like the change that we made and feel like public defenders are a better fit. And so be interested in people's thought. Oh, I walked away. I think we're just interested in doing what we think is going to be best for the client, the respondent.
Okay, and I will ask one more, just because the judge said I could. And I asked this of Brenda, and I appreciate your take too. But even though I don't know it extensively, and your presentation was really quite helpful for me, honestly. The conversations I've had with behavioral health folks have been very critical and negative towards Care Court. And do you have an impression about why that is? I know what Brenda told me.
Well, I mean, that's a whole nother presentation.
I'm just curious, so I have a better understanding of where they're coming
Well,
from.
I mean, I think it's two major buckets. And I think that one would be that any engagement or any use of the court in compelling somebody to participate in treatment is a fundamental issue that in my 25 years of doing this work has divided the community always. And there is evidence on both sides to show that coercive even if it's not, mandating someone to a locked IMD, which there's no authority in care court to do, it's still going to be seen as coercive because the use of the court. And even if the court orders, and the individual doesn't want to participate and leaves and the court dismisses the case, it's still seen as being coercive. So, and there are people who feel extremely passionate and committed to that viewpoint. And I respect that viewpoint. I think there's another group of people who would just simply say, we have a crisis on our streets for all sorts of people. Definitely not just people living with schizophrenia. In fact, that's probably the smallest group of people who are on our streets, and that we're not doing enough to help all of the people who are on the streets. And so I think those are kind of the two main camps of arguments that I hear. What I would say is I want to be respectful of our system partners who I know have been really tried by COVID, who have been tried by decades of underfunding in behavioral health. But I'd be remiss to say that I truly believe that with the 7,000 to 12,000 people that we're targeting for this program, they're exactly the kind of people who need our help now. And we can find a way to have the capacity to help those 7,000 to 12,000 people. And that is the mission of what we do in specialty behavioral health, is to serve this population. So we'll figure it out.
Any more, Matt? Okay. I realize time is very short, so I'm going to try to not ask a lot of questions. I'm very interested, and again, thank you for the presentation on the solutions for IST, because this has been an issue that has just really plagued the courts for years. What I wanted to ask you about was this: the treatment infrastructure funding. If I understood it, that is going to be over a 4-year period.
Yeah, that's correct.
What I wanted to ask you is this: I also heard you discuss at one point that the idea was building or rehabbing to put 8 persons in one. Did I hear that right? In one house. What I wanted to raise, just for your information, because I greatly believe in this program and what you're doing, and I have been. I see these individuals every day, unfortunately, in a criminal setting. And I refer them, and we have diverted a substantial number of individuals who are going to meet those 3 criteria and were being sent to the hospital, other than our ability to place them in the community. And what I have found over the last couple of years, 2 years, is we are having incredible pressure in that we're not placing them at a level of care that they need. In other words, they need crisis residential or a locked facility or something more than we can offer. And then in trying to build infrastructure, and I don't know if I have talked to other judges in other counties, but I am not up to, I'm not an expert or knowledgeable about all the other counties. And I know Los Angeles has been able to put facilities in place. In our county, it has taken 2 to 3 years just to build 16, to expand an existing facility that was closed before, part of it, then to rehab it and get it online again. It can take up to 2 years because of all the licensing, the permits, and all of that. So my concern is, will the counties be able to use this funding over a longer period of time than this 4 years? So because I don't think we're going to be able to build the facilities we need or to rehab facilities fast enough. That's my great concern.
Yeah, no, understood. A couple things though I wanted to just kind of address your comment there around locked facilities or different types of residential settings for this population. Ashley and Stacy had also mentioned in our sort of prior year budget adjustments or related to IST, one piece was this IMD slash subacute capacity infrastructure proposal that we were funded in this 21-22, so last year's budget cycle, and we're currently partnering with a number of different providers to provide that level of setting that is going to be used to complement the sort of lower level settings that we're envisioning will be made available through the infrastructure funding through the IST solution. So we'll have sort of this full array, this full complement, this full continuum when all of these dollars materialize into the different settings. We'll not only have options for those who need to maybe remain in jail because of their crime. We will have, jail-based competency services. We'll also have state hospitals. But then we will have these IMD subacute to help promote that stabilization, provide a lock setting where there may not be as much of a comfort level to discharge directly to a lower level of care. And then ideally, we will also have then these more open settings like LA County has so successfully operated with their 515 beds. And we'll make those available in other counties, but we'll provide flexibility to counties if there are different models of housing that they're interested in and that works for that community's needs, recognizing there are some that are just a little bit more conservative than others. And in terms of distribution, we want to distribute the funding within that 4-year period. And yeah, we want to aggressively try to scale up as many houses as we can within that 4-year period. But there will be some latitude, recognizing that in year 4, funding is going to be distributed, and then it might take another 2 years for some of those projects to kind of materialize. So there will be some flexibility there.
Good. That's wonderful to hear. I have another, really a question and just a comment that as I said, I've noted that we need far more crisis residential settings that we have in our county. And we're seeing, the challenge now is similar to what you have in the state hospitals. We have a wait list to get out of the jail into the diversion program because we've referred so many people. But one of the things that I think is really important that you talked about is you're going into the jails and helping them understand how to provide meaningful treatment while the people are in jail. We have started a program just having nothing to do with the state hospital, but for people who have already been found incompetent and committed, to revisit that and have them assessed for diversion by our own behavioral health department. And what I have found is that we're getting some very positive feedback because it does require in our particular court and county, the district attorney must agree. Everybody has to agree to this because we're changing to come in from the state hospital, and the judge is not. It's just the way we decided to do it, but it's working successfully. But I really think it's important that while they are in jail, we make sure they get the treatment, and we train custody health or the contractors that are working in the jail with people about using long-term injectables, how to convince individuals to take medications when it's been ordered, but they don't want to take it. And I understand that. I deal with it every day, so I'm very familiar with it. But I really think that is a place that you should really put as much effort as you can, because the better job we do early on, I think the better results you're going to get long term.
Totally agree. Thank you for that comment. I will share that one of the recommendations that came out of the IST Solutions Workgroup, and I believe that was from Sheriff Barnes, was a recommendation to develop an involuntary medication order toolkit And so we have started on that process and partnering with the Sheriff's Association to develop that, and that will be shared among the other sort of groups for review and feedback once we put that toolkit together. So we are doing that, and Dr. Warburton very
Oh, yes.
well, right. And so as she says, right, just give us a call if you need help.
Right, and I have done that, and she's responded, and then,
Responded, and so we do have a PRN team who will help support the jail psychiatrist providing that sort of technical assistance. And then also, as you said, through, as Stacy had mentioned earlier, part of our IST solutions is this early access to treatment. So, we really only have responsibility for treatment as soon as someone is committed to the Department of State hospitals. And so, but oftentimes they are waiting for long periods of time. So the idea with this early access is for us to fund the jail mental health treatment providers. So the WellPaths of the world, Liberty, maybe it is county behavioral health that's providing services in that jail. Provide them that additional funding to enhance their service levels, provide additional funding for the nurses and the clinicians so that we can engage treatment at the earliest point possible, primarily around trying to assess that need for medications as soon as possible so we can start that stabilization. But the ultimate goal is not just trying to deliver that treatment and provide that TA around involuntary medication or access to medication, but it is also to try to promote more individuals going into diversion or a
Right.
community setting, and so that key really is stabilizing as soon as we can.
right,
So-
wonderful, I think, and thank you very much. I'm not going to make, I won't ask any questions about care court. I will state I am a strong supporter of the program, and I have said enough. And we're short on time, so let's go ahead and
Let's,
open up.
how about some participant questions? Thanks, everybody. This is really great conversation. So I do see that we have Linda Kaufman in the chat. For anybody else who's interested in asking a question, please raise your hand, but I'll read the chat question first because I saw that pop up. Can a mental health provider contract directly with the courts versus county behavioral health, or must all referrals come through the behavioral health system of care? And that might be a care court question.
Yeah, I think so. So the referral system starts with a petition, and so any behavioral health provider who obviously knows the person that they're placing a petition on can submit. It does not need to go through county behavioral health. You might be familiar with the way that Laura's Law or AOT in California works, of which you do have to submit everything to county behavioral health first, and then they are the conduit to the courts. So that is a fundamental difference between care court and assisted outpatient treatment. Because the courts are holding the counties accountable for those government partners, certainly as a contractor, you may be the contractor for, say, the Forensic Full Service Partnership, which will be, if a county has one of those programs, obviously it would be that program, or a regular FSP would be an ideal level of care for someone who meets the care court criteria. So you might be, as a provider, the contractor who's really delivering the care or providing the housing, the enriched housing environment, et cetera. But you as a contractor are not the entity that's quote unquote responsible as part of the issuing the court orders or complying with court orders.
Thanks, Stephanie. Hopefully that answered that question. And then I don't see any hands raised. Am I seeing it? Questions from our participants? I know. I was expecting that. Oh,
Very
looks like-
rare.
did we have one come up? Steve, we have Steve McNally. Steve, please go ahead. Yeah, you should be unmuted and able to speak now. Steve, are you there? I think you have to unmute if you're talking. It's showing you as muted on our end still. Okay. Well, Steve, if you can hear us, unfortunately we can't hear you, but you're always, if you have some thoughts you want to share with us, please send them to our email address, ccjbh@cdcr.ca.gov, and then we can follow up. Okay. I guess with that, Paige, if you wouldn't mind putting up our last slide so we can go through our last steps. But I just want to say a big thank you to our presenters today from the California Health and Human Services and Department of State Hospitals. Wonderful efforts going on. We'll be looking forward to continuing discussions and working with all of you in the year and years to come on all of these amazing investments and opportunities to really focus on our goal one, which is reducing the prevalence of rates of behavioral health, individuals with behavioral health needs in jails and prisons. So thank you so much. And moving to our upcoming events, our last slide, our work group meetings. So the juvenile justice work group and the diversion and reentry work group meetings. The next diversion round of them will be in September, on September 16th. And then our next full council meeting is in a couple of weeks, July 29th, and we'll be focusing on workforce. We'll have HCI there, the Healthcare Access and Information, formerly OSHPD, who will be talking to us about all the work they're doing to invest in behavioral health workforce, particularly under the Children and Youth Behavioral Health Initiative. And then we also will have a presentation from our very own Chief Jenkins and Jeff Twitchell, who's been here in the past before, talking about educating or training individuals from behavioral health and working with individuals who are justice involved. So looking forward to that as well. As always, we have our website available and our email account listed. So if anybody wants to get a hold of us at any time or share information, we're always looking for that. And if you're interested in being added to our CCJBH listserv, we really want to invite you to do that as well. If you're not already part of it, to know if you're part of it, you should be getting emails from us every single Friday. And we compile information. We put our work group and full council meeting information on there. And we also provide partner information in all the sectors that are responsible for providing services to our justice involved population of individuals with behavioral health needs. So with that, I think that it is 4:58, 2 minutes early. What? I know. But thank you so much, everybody, for spending time with us this afternoon, to our guests for sharing their subject matter expertise and generously sharing time with us, and to all of our participants as well for tuning in and for the great work that you all do in this space. So we'll look forward to continuing conversations and seeing you all next time. Hope everyone has a wonderful weekend. Oh, a big shout out to our CCJBH staff team. Oh my gosh, you guys are amazing. Emily, we got Paige here and Monica, and we have Liz remotely who's been helping us troubleshoot. So thanks everybody. Couldn't do this without you. So all right, everybody, have a great weekend. Thank you.